Hello, everybody. 7 o'clock almost. We are very happy to welcome you on this first pediatric webinar. We have well, first of all, we have an outstanding panel today to speak about Paediatric Early Warning Score, but I will let our moderator to introduce these wonderful speakers. Before we start, I have two announcements to do. First one, this session will be recorded and it will stay on the website of the ERC for 3 months so that you can review it and other people can register and have an access to this webinar. So it will be very interesting if you need to review something. If you have questions during all the session, you can write it into the question and answer, the chat, and our moderators will check on it and will ask the question to our panelists during the pause between the speaker sessions, but also at the end of the webinar, we will have a panel of questions and that will be with your questions. So first of all, I will introduce Jimena del Castillo, which is a member, very active member of the SEC PLS, and also our young ERC, Francisca Markel. First, Jimena del Castillo is an intensivist and she is working in Madrid. And Francisca Markel, is a pediatrician which is training in pediatric cardiology, and she's working in Leipzig in Germany. So thank you for all of you to be there, and let's go for this webinar.
Thank you, Dominic. So good afternoon or evening, and welcome everybody to this webinar on pediatric life support. Today, we have 3 excellent panelists who are worldwide experts on pediatric early warning systems. As you already know, ILCOR's latest constraint regarding pediatric life support review PEWS. Why? Why PEWS? Why pediatric early warning systems? Well, if we think of hospital care, when we look into resuscitation, we have to consider it as a reactive response to the deterioration of the child. This leads us to thinking that early identification of the vulnerable child offers an opportunity to mitigate and potentially avoid critical interventions. And prevention is key to survival. Tonight's talk will explore the current landscape of PEWS from our experts' point of view, their understanding of them, and the different approaches to implement complex organizational-wide systems and review technological facilitation to improve system uptake, sustainment, and outcomes. Our first panelist is Dr. Ursula Gawronski. She's the Medical Directorate for the Healthcare Professional Development, Continuing Education and Research Unit in Bambino Gesù Hospital in Rome, Italy. Our second panelist will be Karen Dryden-Palmer, who's an advanced practitioner, nurse leader, and clinical nurse specialist from Toronto in Canada. And our final panelist is Dr. Jerry Sefton, who's the co-chief investigator for the DETECT study and advanced nurse practice in pediatric intensive care and the Institute for Child Health, Alder Hey, in NHS Foundation Trust, Liverpool, from the UK. Distinguished panelists, hello everybody. Well, distinguished panelists, the floor is yours. I hope you all enjoy it.
Okay, thank you very much, Jimena, for this introduction. So I will share my screen. Okay. You see, well, my slides. Perfect. Okay. So my talk is going to be on the current landscape of PEWS, and I'm going to start with saying that PEWS is an intervention that operates as part of a whole hospital process for the recognition and response of clinical deterioration on hospital wards. But traditionally, the focus has been on the score, but actually it needs to also encompass the system. Because if we look at the chain of prevention by Smith, we can see that the PEWS score is just one of the elements supporting the recognition of deteriorating patients, while the system, the PEWS system, affects the whole chain, including education, including monitoring, so the way we monitor, what we monitor, including communication, so how we communicate with senior team members, and the response that we put in action to prevent critical deterioration. So just more than just a score, PEWS are complex system interventions. PEWS scores are frameworks, but even more structured approaches for evaluating routine physiological and clinical data for early indication of evolving critical illness. And we can say that in pediatrics, because of age-associated variations in physiological signs, one single PEWS risk model would be inadequate. And for this reason, PEWS usually refer to different vital signs thresholds for different age groups. Also in pediatrics, there is a limited ability in children to compensate for serious illness if we compare them to the adult populations. And this means that we have a more limited time frame to act in order to prevent evolving serious illness. So the PEWS is configured to work as a proactive screening tool to identify evolving deterioration by looking for physiological and clinical signs associated, for example, with shock. So through the shock example, we can see that in the early phase of evolving shock, the body initially works harder to compensate, to preserve core functions. And usually PEWS scores are elevated, which should prompt the response of ward staff to question really what is going on with these patients. And early recognition provides a window of opportunity to examine, to investigate, to review labs, to deliver interventions in an attempt to stabilize the situation and to prevent the deterioration progressing. But however, if deterioration is recognized late, then deterioration can progress to become critical with signs of decompensated shock. And at this point, deterioration speeds up, and it takes an enormous effort to rescue the patient and prevent respiratory or cardiac arrest. So what we are advocating here is that PEWS can provide a safety net and pushes attempts to rescue from being a reactive process to a proactive process in order to intervene much earlier to improve clinical outcomes. So early warning of what? What are we trying to flag? So prospectively, we're looking at any serious illness or clinical deterioration, but we're also looking at significant comorbidity that might adversely affect the outcome of our patients and increase their risk. And we're looking at critical deterioration, which means at any event potentially leading to an unplanned PICU or HDU admission. From the point of view, instead of a retrospective look at what happened to our patients, our endpoints that indicate failure to rescue are usually cardiac arrest or any call to the resuscitation team, any unplanned HDU or PICU admission, or any unexpected death. Now, in children, deterioration that progresses to become critical can be catastrophic for the child and often requires emergency admission to a PICU, which we all know that it is known to increase both the hospital length of stay and risk of mortality. But studies have also shown that there is a window of opportunity to prevent serious adverse events, such as cardiac arrests, especially when children show signs of physiological instability, and those signs are recognized by staff. And this suggests that if clinicians focus more their attention on those, then outcomes might be better. And in 2008, there was a confidential inquiry on child death that reviewed 89 cases and showed that 70% of those cases were associated to failures in direct care or potentially avoidable factors, meaning that there is really quite a window of opportunity to prevent those cases. So PEWS provide criteria for early identification of patients at risk, and also criteria for early activation of what should be the appropriate resources, the appropriate teams to respond to that potential and evolving clinical deterioration. And there are several types of PEWS that have been described. So we do have single parameter systems where the response algorithm is activated when any criterion is met. Then we do have multi-parameter systems that require more than one criterion to be met. And then we have aggregate scoring systems where scores are assigned to physiological values and compared to predefined thresholds. And then we have combination system, which might include single, multi-parameters used in combinations with aggregate scoring systems. Now, a PEWS is a complex multifactorial intervention, and these are only three, let's say, elements that need to be deeply explored and that compose this multifactorial intervention. So first, there is a score. And this means that a score needs to be chosen, needs to be identified, and that a choice needs to be made on which observations, which vital signs are going to be included in this score, are going to be monitored for our patients. What type of monitoring are we going to be expecting for our patients? The frequency of routine monitoring, but also of increased monitoring when they deteriorate, and also the expected completeness of monitoring. Then there is the response that needs to be built and organized. So the interventions need to be defined, the resources that we're going to be dedicating to this response, and then the criteria that are going to be activating the response to deteriorating children. And then final, but not least important, are the outcomes. So we need to establish an outcome measure in order to understand and monitor if the PEWS that we have in place is reaching our expected aims. Now, there are different outcome measures, but the critical deterioration event outcome measure is gaining particularly attention in the last years, as it is more frequent than other commonly measured outcomes, such as children's deaths or cardiac arrest. It's 8-fold more common than cardiac arrest, and it's also associated with a 13-fold increased risk of mortality, which makes it an interesting outcome measure. Now, as far as the validation of PEWS, now there are a couple of excellent systematic reviews that have been published, and the last one by Truby shows that there is a wide number of PEWS that have been developed and they've been evaluated in specific local contexts. But this large number has been narrowly validated. They're all single-centered studies. There's only one multi-centered study, and none has been validated across a variety of population and settings. And moreover, there are primarily observational studies with an elevated risk of bias, being many of them based on retrospective chart reviews with missing data and also with the risk of underestimating deterioration, particularly these missing scores, this missing data is considered as normal. Also, what we have found is most PEWS have a low positive predictive value, and this is reported particularly in studies that are adjusted for outcome prevalence, suggesting that there is a potential for alarm fatigue. And this, even with PEWS that demonstrate a good performance, even those they're likely to generate a large amount of false alarms, just because the outcomes in pediatrics are rare. Another issue that needs to be considered is that the implementation is often poorly reported. So inter-rater reliability or accuracy of scoring is often not reported. And essentially, there's no agreement on which should be the essential components of PEWS or the weighing between them, the frequency of monitoring, the optimum thresholds, or escalation of care. We do know that in the implementation of PEWS, there is often issues of completeness or incorrect calculation. In terms of fidelity of the implementation, we know that when PEWS based on paper charts are used, errors are common. And there is one study that describes how errors are often more towards the underscoring as opposed to overscoring. And this is a problem because what was found was that a proportion of those underscorings were clinically significant, which means that the PEWS score was not actually reflecting the severity of illness of the child. And again, issues of inter-rater reliability that is often low. Now, the PEWS score matters. So we need to choose also the right score, or possibly the best performing score. And this study, which was a retrospective case control study, the author compared 12 scoring and 6 trigger systems in order to define and describe the performance of those tools. And the tools, they were ranked, and the top 3 best performing tools had a ROC greater than 0.87. And those are the Cardiff and Bell, the bedside PEWS, and the modified PEWS. The least well-performing tools were the trigger tools, which they have a greater sensitivity, but they have a much lower positive predictive value. So they are the ones to be less recommended. So the choice of the tool we decide to implement is relevant. In terms of the effect of PEWS on reducing morbidity and mortality. Now, despite the large number of publications, the evidence to support their use is still quite limited. So it is still not clear whether they really improve patient outcomes. And when they are implemented as a standalone intervention, the evidence to support the effect of PEWS on the most important patient outcomes, such as child's death or a PICU unplanned transfer or a cardiac arrest, then the evidence is quite limited. But on the other hand, when a PEWS is implemented as a package of intervention, which means associated to staff education or to the presence of a rapid response team, so a team of specialists dedicated to respond to deteriorating children on the ward, then the evidence is moderate to low, but there is some evidence of improved outcome. Conflicting evidence is reported on the effect instead on PICU urgent admissions, and most studies have been performed in specialist centers, meaning that those studies are not possibly generalizable to non-acute settings. EPOC. Now, EPOC has been the first and only randomized cluster multi-center trial that has been performed on a pediatric early warning system. And both my hospital and Karen's hospital was involved in this trial. My hospital was randomized to intervention. So we did have the luxury to introduce the bedside PEWS in our hospital, supported by the EPOC implementation team, which was fantastic, I have to say, and a great help. So large trial, 21 hospitals internationally, 10 hospitals were randomized to intervention, 11 to usual care. The primary outcome was all-cause hospital mortality. Several secondary outcomes, including significant clinical deterioration events, which was a composite outcome reflecting late ICU admission, and then other process outcomes, including also ICU outcomes. What was found, was disappointingly that the findings did not support the use of the bedside PEWS to decrease all-cause hospital mortality, nor there was a positive effect on all the other process outcomes or ICU outcomes, except for significant clinical deterioration events, meaning that the hospital that used the bedside PEWS transferred their patients to the PICU less sicker, so in a less severe condition. Now, this trial has been incredibly important, but there was probably one issue, one problem of being underpowered, and this because the rates of deaths on the hospital pediatric wards were much less than expected. And then, so possibly this significant difference between the intervention hospital and usual care was not possible to be identified because of this issue. Another positive finding of this trial has been that the frequency of vital signs, and especially of documentation of vital signs, of 5 of them, was increased in the bedside PEWS hospitals compared to the usual care. So practice changed on the hospital wards in a positive manner. So to conclude this presentation, so PEWS are increasingly used despite, however, the limited validation, despite limited evidence reported on the PEWS implementation fidelity, limited evidence on escalation practices, but also on outcomes. We do need definitely homogeneous outcome measures that are essential for the evaluation of pediatric early warning systems in order to be able to compare outcomes between centers, between different settings, and among different studies. There is definitely an opportunity for improving the performance of PEWS through digital innovations, and here Jerry will shortly speak about this, but also the use of population data that is now more and more available on electronic health records to increase the precision of those systems. And last, we may in the future also start reasoning on the role of other team members. And here I'm thinking about parents, that through their valuable contribution, they might be an additional element that might be key to increase the performance of the pediatric early warning systems and scores. So I thank you for listening, and I am happy to receive any question or to move on.
Thank you very much, Ursula, for this very great overview of the pediatric early warning score. I would like to present some resumes or of 2 polls that have been active during your talk. We asked the participants of this webinar if they think if the implementation of PEWS is important for resuscitation. We do have 80 people that answered that question, and mostly with yes, so 91% think it's very important. There is 1% that says no, and 8% say they don't know. Mm-hmm. Another active question that we ask is if the participants have a PEWS system in the wards at their hospital. We do have 46 participants that answered that, and 37% do have a pediatric early warning score at the ward. Which I think is great. 26% don't have it, and some just have it on some wards, and 17% say they don't know. As for questions, maybe the participants have to warm up a little more, so there are no public questions, but I would like to ask you a question, if you're okay with that.
Sure.
You said, I have a lot of questions, but you said that underscoring is more often than overscoring, and I wondered why that is. What do you think? Why is that?
Well, I think that there is a tendency to sometimes to underscore, and I think there may be different reasons. Sometimes because there are patients that have high scores because of chronic conditions, and they might trigger a response that nurses may feel is not appropriate for them. And this may be a reason for maybe inadvertently miscalculate the score, or simply provide a score that is more, that might be based on the perception of the nurse at that point in time, as opposed to just a calculation error. I think there might be something of this sort.
Thank you very much.
Because I've seen this happening also at our hospital.
Right. Yeah. Do you have questions, Jimena, or the other speakers? Would you like to?
There's a question. There's a question in the questions and answers in Slido, and Basil Iqbal side is asking, how often do you need to check PEWS?
Okay, this is, as I said, there is no agreement on how often you should calculate a score or how often you should monitor your patients routinely. So different hospitals have different practices, and this depends also on the resources that they have, but also on the type of patients possibly that they have met on their wards. There are different publications on what is a consensus of experts. For example, for the bedside PEWS, the recommendation was to monitor routinely patients every 4 hours and calculate a score, because 4 hours for a patient that is deteriorating in pediatrics is quite a long, can be a very long time. But there are different practices, I think, in Europe and in different countries and different hospitals. So there's no,
Right. Thank you.
On this.
Another question arrived. We do have time for that, I guess. It says, what do you think of an adult MET used to respond to news transitioning to PEWS? We have no pediatricians on the team.
Mm-hmm. Okay. So transitioning to PEWS, well, I think this is an excellent plan. I mean, if you do respond to pediatric patient, you do need a PEWS. You do need a pediatric early warning system that captures that variability in vital signs that is typical of the pediatric patient, because you might be responding to a newborn and at the same time to a 15-year-old child. So I think this is an excellent plan if this is what you are planning to do. I hope I responded to your question.
I think so. There are other questions, but due to the time, I would say that we try to answer them simultaneously during the talks, or we will answer them in the end. And I would like to ask Karen to now move on with her talk, please.
Oh, thank you very much. Let me just pull up my slides and let me know that you can see them. Do they look okay?
Yes.
Okay, wonderful. All right, thank you, Ursula. So first, I'd like to take a second to thank the organizers for the opportunity to participate in the discussion today, and thank all of you who have tuned in, and those of you who've accessed us after the fact for the recording. For my part of today's presentation, I'll be sharing some theory about innovation adoption in complex organizations, which we know hospitals are, as well as some of our own experiences in EPOC implementing the bedside pediatric early warning system. So my connection to this work is through my role in EPOC as the implementation lead for the bedside pediatric early warning system. And to date, we have implemented bedside PEWS now in over 30 international hospitals. And some of the publications from that work are listed up there for you. So just to refresh, our objectives for this section of the session will be focused on exploring approaches that are helpful when introducing system-wide change in complex hospital settings, and the importance of thinking about how to implement and sustain a pediatric early warning system intervention. And that importance, I think, should never be underestimated. So first, I'd like to situate us in a little bit of implementation language. Firstly, the innovation. So the innovation is the thing, the new thing that we're introducing into practice. So in this case, we're talking about pediatric early warning systems. Implementation is the actions that you take or the program activities you plan and the processes that are involved that are intended to move the innovation into practice. The intervention is the actions that you take within that implementation program to promote awareness, acceptance, and uptake and change behavior of providers. And adoption is choosing to make the change and take on the behaviors and actions associated with the innovation. I think it's really important to note that adoption occurs at multiple levels, including individual level, team level, organization, and system level adoption. And then finally, implementation factors. And these are elements that are associated with the implementation process that either facilitate or inhibit successful implementation. You often see these described in the literature as barriers or facilitators. And in our work, we intentionally use the term factor because what we have noticed is that what might present as a barrier in one implementation setting may function as a facilitator in another. So we work very hard not to weight these items because they're very context dependent. So for an example, a top-down led implementation in one organization, so very sort of directed, may be very successful, whereas in another setting or another hospital system, that type of structure might create challenges to effective implementation. So why is it important to pay careful attention to planning and managing implementation? Basically, the generation of new evidence to advance practice is costly and intensive. In Canada, the Canadian Institute for Health Research estimates of spending nearly $1 billion annually to support evidence generation for health care. And application of that new knowledge is equally expensive and time-consuming and labor-intensive. So current approaches unfortunately result in unpredictable and uneven success at moving all this great information to the point of care with patients. So therefore, there's this gap between the available evidence and what is actually applied in practice. So studies of various implementation techniques and knowledge translation tools have demonstrated that improvements are usually only partially taken up or take years to impact care, and little is known about how these innovations are sustained over time. So most of the work informing implementation science to date has focused on 3 domains, either the organizational characteristics, the factors related to the individual operator or provider, and items related to the innovation itself, looking to these 3 areas to explain why some implementations and innovations are successful and others are not. For the most part, linear conceptualizations of knowledge uptake have dominated our thinking about implementation in these processes. And this is based on the assumption that a reasonable clinician, when given access to evidence, will logically integrate that information into their practice. However, we know that that is not actually what happens, and it's not always the case. I think the MERIT study is a great example of this, where the investigators found a low rate of calls preceding unplanned ICU admissions, even when the calling criteria was present for the patient in their study. And they really described the challenges of being able to unpack that phenomenon as a problem either with the innovation itself or as a result of an incomplete implementation. So now there's an emerging perspective change about understanding how implementation in healthcare works and conceptualizing it as dynamic and responsive that involves an interface between the innovation, the user, the organization, and the multi-factors that make up the context for implementing that innovation. So this new perspective acknowledges that the innovation itself changes when it's introduced into an environment, and the environment is changed by the introduction of that innovation. And both of these are shaped by the processes we choose to implement the innovation. Now, Ursula mentioned earlier about the complexity of pediatric early warning systems. So I thought we'd look specifically at what that actually means in terms of health system innovation and how to set yourself up for successful change. And we know that change in health systems is both complicated and complex. So a complicated innovation or process, is complicated if the components can be separated and dealt with in a systematic way. A complex innovation allows for no such degree of order or predictability. So a complex innovation is more than and different than the sum of its parts because its parts may interact in unpredictable ways. So complexity can arise from the innovation itself, the implementation that you've chosen, or the specific interventions required, or the setting for implementing. So there's multiple sources of complexity, and I've got them listed there. Pediatric early warning systems embody all of these complexities. They require multiple steps. The system relies on multiple providers or groups of providers. The systems are applied across diverse contexts within a hospital and within specialties. And hospitals are influenced by social connections and relationships, both within the organization and external. So this includes leadership, end users, decision makers, funders, patients, and families. So in response to that, in the EPOC study, we developed the Phased Reciprocal Implementation Synergy Model, or PRISM model, and it's a framework to address these complexities and guide implementations of complex systems like pediatric early warning systems. The implementation progresses through phases. The phases are preparation, introduction, activation, and integration. And you can see there's reciprocal interactions between the innovation, the implementation, and the context, which are represented by those gray circular arrows. During implementation, synergistic adaptations occur and are facilitated as implementers and end users refine the fit of the system and the implementation processes. And as such, the innovation actually changes, and that's represented by that gray area changing shape. And in the integration phase, implementation activities then become part of routine, and they start to fade into the background and the landscape of the organization, and they're no longer seen as another or a separate part of practice. Implementations can light either below the line of fidelity, there's fidelity threshold there, which is a dotted red line, or above it. If it's below the fidelity threshold, the application of the innovation is limited and is no longer linked to beneficial effects. And adoption that falls above the fidelity threshold is linked to innovation uptake as intended, and it has a potential then for extension of the innovation into new domains and areas of practice, which is what we'd like to see happen. So we developed 6 principles to address implementing the bedside PEWS system in the context of the EPOC trial, and I'd like to share those with you now. And these principles tap into individual and organizational motivations for adopting bedside PEWS and are proven mechanisms for individual and team behavioral change. and they address necessary adaptations of the innovation and implementation activities to fit the environment and support uptake of the system to ultimately normalize it for providers. So our goal for the implementation of bedside PEWS was very pragmatic. We wanted to successfully integrate the system operationally and normalize the use of the system, so it's no longer seen as special or extra. So in the first principle is a phased approach, phased design approach, and I talked earlier about the 4 phases. It's a means to mitigate the complexity of the innovation and of the implementation activities. And this table itemizes the focus and goals for the bedside PEWS implementation across all 4 phases. The benefits of a phased approach are reducing the complexity by breaking down and sequencing activities, the ability to pilot test the innovation in situ, and that will surface expected and unexpected impacts that can be addressed, the ability to tailor implementation activities to specific needs and timelines of various user groups, and pacing of the implementation program to align with other organizational goals and priorities, because we do not do this work in a vacuum of other activities. So really the takeaway messages in terms of phasing is to recognize that it will reduce complexity. We found it very successful to do that. It allows you to pragmatically keep and manage large-scale change and keep abreast of ongoing interactions between the system, the users, and the organization. We did not find that choosing either a hospital-wide all-at-once approach to implementing or stepwise implementation approach to be superior from one another. Phasing worked in both of these models, and objectives for each phase were cumulative. So you must mind the timelines. Customization processes, for example, should be completed prior to integration, so you're not complicating learning and unlearning for end users and trying to roll back things that you want to change later. And things like education that takes place early in the preparation phase, we found was far removed from use in the introduction phase. So education tended to erode and we needed to refresh education. The responsiveness of the program was designed to attend directly to those dynamic interactions between the innovation, the organization, and the implementation processes. It benefits because it improves fit of the implementation to the local environment. It allows for in-process adaptations and short loop adaptations and feedback that addresses real-time impacts for providers using the innovation. Intentionally embedding this responsiveness allowed for implementers to anticipate and monitor for operational signals to adapt their implementation activities in process. So for example, aligning timelines with organizational priorities when there are competing demands for resources. So the pearls in terms of being responsive is to really look at short loop cycles and interval feedback to end users because those were very effective to facilitate local fit while preserving innovation integrity. And that hospital structures that required multiple layers for decision-making or a centralized implementation oversight struggled a bit more to keep up with the pace and respond to threats and emerging challenges during the implementation. Third principle is customization, and this is intentional and thoughtful customization, and this is again concerned with improving the fit of the innovation to the local use context. We found customization occurred organically, resulting in unintended modifications in the innovation and potentially limiting its desired effect. So planning for these processes allowed us to protect the non-modifiable components of the system from erosion or misapplication. So customizable implementation planning allows for attention to different cultures of practice within the organization and flexibility in the materials that you develop for end users to support them implementing the practice changes that are required. It allows organizations to play to the strengths across teams as well as between teams. Customization also enhanced adherence and implementation efficiency because the innovation became more familiar and easy to integrate for end users. And conversely, more rigid implementation designs did not address the different local needs of teams within the hospital setting. So it risks these alterations happening at point of delivery in an unregulated way, potentially blunting the desired impacts of the innovation and leading to rejection because the innovation did not achieve targeted outcomes. So customization, I can't stress the importance of determining at the outset what the components of the system can be modified and what cannot be modified in order to protect the integrity of the innovation. So clarifying that expectation at the very beginning is important here, and implementers must be checking and rechecking that the system is being utilized appropriately throughout the process. For the bedside PEWS implementation, the customizable elements were adapting tools to meet local language, or organizationally specific roles and titles in the escalation pathway. The fixed elements that were not modifiable were the scoring threshold, the levels of escalation that they linked to, and the application of the tool as a screening tool across all populations. In terms of customization of the implementation program itself, most of us are likely quite familiar with and generally accept the benefits of fitting educational approaches as part of introducing something to new practice. So tailoring the education is important in the implementation to avoid opacity for the end user's expectation and to ensure end user skill is established. Organizations and implementers need to ask and answer these important questions here about how education is best delivered and evaluated in their context, and operationalize those pathways. Failure to recognize or act on gaps related to applying a pediatric early warning system and the skills involved can really sink an otherwise well-performed implementation. For example, if there's a gap in the end user's ability to correctly take a blood pressure or utilize a practice or a clinical tool to complete the assessment that's necessary. So it's important to remember that education alone, however, has a small effect on changing provider behavior. Adult learning theory suggests to us that when education is coupled with other interventions, the impact is improved. So interactive sequential learning opportunities that are relevant to the practice context for the learner and reinforced with complementary strategies like social mechanisms, champions, audit and feedback, reward and recognition, all have positive impact on successive implementation. And here just a listing of some of the implementation interventions that we used in the EPOC study, listed by type, but you can see that the effects are generally small to moderate. And this is why I think it's so important that we plan implementation to determine the combination of strategies that are most effective in your setting. It's actually interesting to note that across all of the EPOC implementations, none of the organizations incorporated the patient-mediated strategies. And there's really growing evidence telling us that successful implementation requires both a push and a pull of change. So the push would be the organization saying, this is the expected behavior and this is the processes we'd like you to enact. A pull would be something like family members asking about their child's PEWS score. So I think there's some opportunities for us to work collaboratively with children and families to help pull that change forward. So pearls for education, once the innovation is launched, a failure to adhere to education might not be the reason that it's not going well. It might not be that there's a knowledge deficit. You need to look also for social influences, competing demands, hidden rewards for other practices, so part of the unlearning strategy, and layer your strategies to plan for that push and pull. And also please measure the impact of your education strategies, then you can revise them as needed. The fourth is end user engagement, which was interestingly looked different in different organizations. And this is involving end users both in implementation planning and in use of the innovation. And this is data from our early review of the bedside PEWS implementation program, and you can see there's a significant difference in how organizations integrated end users, with only 2 sites actually here, half of them involved in frontline staff, and when they did it was for less than 50% of the implementation interval. So end users can be active as consultants, decision makers, passive recipients, or leaders in the implementation operations. End user engagement should take on the roles that are familiar within the organization and the pathways that are familiar in the organization. And we found that it was important in both top-down leadership initiated implementations as well as grassroots. So it had a viable positive impact in both of those models. So it's also important to identify and seek out those end users who may not be obvious stakeholders, and that will preempt later gaps or operational difficulties after implementation is closed. So embracing end user participation implementation planning enhanced awareness of the need for the change and awareness about the selected solution. So whatever bedside PEWS product you're implementing. It provided transparency of process and strengthened organizational level problem solving. And it can also strengthen end user ownership for the change and sustainment of these new practices. Social influence is the fifth design element, and it's really grounded in the interpersonal support related to practice change. And this approach helps to build trust in the innovation, promote its application, and influence provider behavior in the desired direction at the point of application. So impact and social roles are highly variable, however. There's a wide variety about how the roles are structured and utilized, which roles are used, how their people are selected for them, how they're trained, what type of oversight and scope of influence are all variable across all the different models. These roles are not clearly defined in the literature, and they tend to focus on areas of need as opposed to growth and extension of the innovation. So they tend to look at clinical situations where there's difficulty applying the innovation rather than opportunities to enhance and extend the innovation. And social influences are known to be more effective when combined with performance measures like audit and feedback. In terms of pearls for social mechanisms, reliance on these social roles to facilitate change can create vulnerabilities, so you need to remember that. These include pragmatic challenges like not properly choosing or preparing the appropriate individuals for these roles, or they can also drive a dependency on person-based change, so that behaviors don't change when the person isn't present or the person isn't prompting, which can inhibit the global uptake across the organization. So, and these roles also require organizational oversight and ongoing support. So they need resources and time to do this part of their role. The last is integration and sustainment, the last principle, and it's really about being planned and purposeful in your integration and your sustainment strategies. Leveraging established communication pathways and points of connection between teams and units, as well as maintaining an awareness of what's happening in the whole system, like competing activities or competing demands for resources, are examples and important elements of this integration principle. Reliance on isolated or innovation-specific workflows and pathways can cause discontinuation when the implementation prompting ends. End users will return to previously established behaviors, or the required behaviors are altered such that they're beyond the threshold of fidelity and the innovation benefit will be lost. So integration requires planning for sustainment, both during and after the implementation activities are completed. So in terms of sustainment, sustainment is a degree in which an innovation continues to be used after the initial efforts to secure its adoption are completed. Intentional sustainment planning starts at the beginning of implementation, and it's meant to ensure that the innovation penetrates organizationally relevant reservoirs of knowledge. And this is the framework that we used in EPOC, which are distinguished reservoirs of knowledge, and I have them listed there for you within organizations. So we designed ways in which to situate the bedside PEWS system in as many reservoirs as possible. Accessing organizational memory provides stability over time for the innovation, and it guards against uneven uptake, erosion, and person or role dependent sustainment. So if you lose the person or the role that drives this component of care, you are at less risk of having this practice devolve. So integration pearls, challenges related to integration principle includes a lack of practice focus for an implementation. So this can delay the team feeling that they have ownership of the new practice, or end users may suspend their intent to adopt with the expectation of returning to regular behaviors later. Mechanical implementations that focus on the tasks within the system, so just producing a score or just making calls when the calls are designed to be made, are problematic because they don't fully address the conceptual, relational, and cultural aspects of the new system. So you need to take a wide view of these things in your implementation planning and your integration planning. Linking with established practices and processes in tandem, we found was helpful. Improving outcomes were achieved when the innovation was coupled with other or similar education or practice improvements. So for example, one hospital rolled out bedside PEWS in tandem with a sepsis prevention education framework that they were implementing. And those went together, and so that they helped support each other in implementation. Remembering that having the system say the same over time is not realistic, and it should change as needs change. And some changes can be actually strengthening the system. So it's important to establish a way within the organization to evaluate system success over time. A quick note before I finish about evaluation, and Ursula mentioned some of the challenges in terms of outcomes when we're evaluating similar symptoms. And I'd like to extend a note about not only evaluating the content of the implementation, which is your pediatric early warning system, but also evaluating the implementation. So implementation evaluation involves formative and summative. Formative evaluation informs the customization and fit of the system in process, and the summative evaluation informs the impact of the innovation as well as the impact of the implementation. And both will provide a more robust understanding of why you achieved the outcomes that you did. Why or why not was the innovation optimized, and learn how to do better in your organization in future. It's important to be aware of and follow a variety of outcomes related to system change, and these could be at the individual, team, and organizational or even population levels. Some outcomes to consider are changes in team function, facilitation of shared mental models between providers, the way pediatric early warning systems prompt critical thinking about deterioration, the way it provides a shared language, quantifying patient vulnerability, that it can provide less experienced team members with reference ranges to increase their competence to anticipate and address clinical change. And it can also serve to mitigate power differentials with teams that may inhibit escalation of care. The act of implementing alone can impact teams positively and develop processes in a growth-oriented way. So my final wrap up is that implementations are dynamic and subjected to many influences. Pediatric early warning systems as innovations are complex and implemented within complex systems of care. Multiple interventions that are fitted to the organization support best uptake, and successful implementation of a pediatric early warning system is a result of thoughtful planning, organized support, and attention to sustainment. Okay, thank you very much for your attention, and I'll pass on to the moderator for any questions.
Thank you, Karen. Just to let you know, while you were giving us your excellent talk, we launched a poll question to ask the audience what they thought were the biggest difficulties in PEWS implementations. And I'd like to share with you the results. 9%, 58% answered the question, and 9% thought that work overload was one of the biggest difficulties. 24% thought that individual education on their use and utility was one of the biggest difficulties. Only 7% thought that lack of technological aid or help was one of the biggest things that they have to deal with. And most of our audience thought that all of the above were influencing the difficulties in implementation. Only 5% don't really know what the main difficulty was. And as for questions, as you've already mentioned, the EPOC study, there was one question regarding this study, and the question reads as follows: there is probably not going to be a bigger study than EPOC, so how are we going to get evidence, and whether if it's useful when considering outcomes?
Okay.
So how do we carry on from EPOC onwards?
Well, I'll address the challenges poll first. I think that not surprising that those were the key indicators of challenges, and certainly work overload is significant. And I'm thinking back, Ursula, to when we worked on EPOC. You know, I come from an intensive care environment where we have 2-to-1 patient ratio for nurses. Ursula's organization had double-digit patient to nurse ratio, and those were significant challenges for people because they were seeing the implementation as an add-on task So as things get integrated, that issue lessens. So using that tandem strategy to align the new innovation, regardless of what it is, with an already existing pathway or process of care is a good way to sort of mitigate some of those concerns. And also to really be transparent about when you're doing something like using a scoring system that identifies acuity, that you're also identifying children who need de-escalation. So you're able to better situate your resources where they're needed. So it's not necessarily you're asking for more resource, you're distributing resources based on clinical acuity. But there's always this initial fear that it's all about escalation, but these scores also contribute to de-escalation and matching care with need. So I think that's an important thing to remember. In terms of how are we going to measure this, that's probably a question for many perspectives. From an implementation perspective, you know, there's lots of work looking at models and approaches to implementing that are out there that are being measured. It wouldn't necessarily have to be specific to an early warning system to be applicable because of all of these similar traits in terms of complexity. So I would encourage people to look broadly at evidence around complex system management and introduction for ideas in terms of what outcomes to monitor and how to evaluate those findings. I hope that answered your question.
Thank you, Karen. I hope that does too. Okay, so we will switch on to Gary and her talk now, and we can get the rest of the questions answered by the end of the talk. So, Gary.
Can you see this slide okay?
Yes, Jerry.
Oh, lovely. So hi, everybody. My name is Jerry Sefton, and I'm currently the co-chief investigator for the DETECT study, which is looking at the use of smart technology to help us be more proactive in recognizing children that are becoming more unwell and intervening early. And I'll tell you a bit more about that during the talk. So my background is in pediatric intensive care, and my main research interest over the last 15 years, I dread to say, has been early warning and critical deterioration in children admitted to hospital. So I've been working with PEWS in different formats over that time and introduced several different types at our hospital and have gained a lot of learning over that time. So today I'm going to talk to you about the potential that there is in technology to offer advantages, both in terms of standardizing the care delivered, being able to track process, which really is measuring the fidelity of your implementation, providing real-time situation awareness about deterioration and whether this is able to improve clinical outcome for patients. So this little logo that we've got here is the logo for the DETECT study, is a magnifying glass, because we're looking at all of our children in hospital with close scrutiny. So in this session, I'm going to touch on the current evidence about electronic early warning systems and their impact on critical deterioration. Then I'm going to talk about the importance of tracking process and allowing that to be associated with improved outcomes. And finally, I want to be honest about the organizational investment required to reap the benefits required in having a smart technology delivered PEWS. So I think Ursula and Karen have given a very good introduction for me in terms of outlining the gaps of evidence available in PEWS. And I think there are several reasons for this. And probably one of the biggest reasons in comparison to adult studies is that in pediatrics, we're still predominantly using paper-based monitoring systems for keeping oversight about our children in hospital. And using a paper-based system means that we've got limited ability to control the behaviour of staff and to standardise care. So we're reliant on staff making reasonable decisions about what vital signs they document and the interval at which they screen children for signs of deterioration. The advantage of using technology to support us is there's a possibility to force change to standardized surveillance and then track the compliance with your intervention and outcome. The other issue with paper-based systems is that staff have got to remember a certain amount of knowledge in their own heads about which thresholds are concerning for children of different age, they also rely on staff making the decision to escalate their concerns to the next person in the hierarchy to get help for the child. So when we look at the evidence, the idea of using technology to help in detecting early deterioration is not new. There's been studies in adults for more than 15 years. There's only a very small number of studies that have looked at admission to ICU and outcome as an endpoint. So I've summarized the clinical effectiveness data here in 2 forest plots. So the one on the left is looking at the use of early warning systems, associated critical deterioration and ICU mortality. And the 2 biggest studies, Bailey used early warning with real-time alerts in a cluster randomized study in the USA and had more than 20,000 patients. And Belomo led a controlled before and after study in 5 countries and also looked at more than 20,000 patients. And their focus was standardizing monitoring and alerting the early warning teams. And Belomo and Bailey were the only 2 that showed some benefit. Then when we focus on early warning systems on the right, we are looking at early warning, critical deterioration and the length of hospital stay. And there was 3 studies that showed benefit for this intervention at reducing hospital length of stay. So one was Jones, a UK study before and after, looking at 1,500 patients, and they looked at using real-time alerts to improve situation awareness and targeted time response to patients. Then there was Coliff, was a US study on 8 units, and it was a randomized controlled trial where wards that were randomized to the intervention, the alerts from the system went to the rapid response team and they tracked actions, and the wards that were not randomized just collected the data, but the alerts weren't sent through to the rapid response team. And finally, we've got SUB, which is a Welsh study, which was a prospective before and after study of 5,000 patients with paged alerts. And those 3 studies showed benefit in reducing hospital length of stay. Oh. So the idea of using smart technology as our vehicle for monitoring children in hospital is also not new. So we've got this study that was conducted in 2 large university hospitals in the UK used Apple iPods to be able to document vital signs and to track what was going on with patients. And they were able to show that there was an association with increased monitoring and a reduction in mortality in those 2 large university hospitals. And the data that was collected during that study formed a huge repository of data that allowed the generation of the National Early Warning Score that is now routine practice in the UK and is currently on its 2nd iteration. So the National Early Warning Score was approved and endorsed by the Royal College of Physicians, and the standard of care is that should be used in all inpatient areas treating adults. Unfortunately, there is no such technology that has been robustly evaluated for use in children. There is some small areas where there's been bespoke development of such technology, but never been robustly evaluated. So the study that I'm involved in is the first study of its kind to evaluate this type of technology for children in hospital. So DETECT is dynamic electronic tracking and escalation to reduce critical care transfer. This is an NIHR funded study, and the study has got 3 main arms. to explore the clinical effectiveness of the technology, the clinical utility, which is really the acceptability to the clinicians and to the patients and families being monitored in this way. And the final strand was looking at the cost effectiveness of the technology in a UK NHS environment. The study is supported by 3 universities, and we are working with the company System C as our industry partner. So the setting is a single site. It's a whole hospital study. And Alderhay, for anybody that doesn't know it, is a standalone children's hospital in the northwest of England. It provides the local paediatric service to the city of Liverpool and the surrounding area, and also provides tertiary specialties for the whole of the northwest of England region. The hospital is a designated trauma centre, and it's got a 24-bed paediatric intensive care, which offers up to level 4 PICU care, which is ECMO, and it has a separate 19-bed HDU. And for the purpose of the study, we included 10 inpatient wards, which was 240 beds. So the study is a mixed method study that was originally planned to be over 3 years. And as I said, it was entirely prospective. So we had a baseline year from March to February 19, where we observed what was happening in existing practice, collected data about all of the children in hospital and deteriorations, and we also collected vital signs. In the second year, we started developing the bespoke intervention, and we started preparing the organisation for the intervention. And halfway through the first year, we launched the intervention in a stepwise approach across 10 inpatient wards. Then our planned post-intervention phase was meant to be 1 year, from March 20 to February 21. And I'm sure you'll all recognise the date, but that was the March 20 was the time when the pandemic hit the UK, and obviously changed a lot of things in healthcare. So at the time this happened, we had discussions with our funder, and the permission was given to continue the study on safety reasons, because there was real concerns that withdrawing the study at that point might mean that children in hospital would go unnoticed if they were deteriorating. And there was also concerns that staffing would be adversely affected during this pandemic. So we collected data for a further year, but felt in light of the pandemic, it would be inadequate to be able to make claims about the effectiveness of the intervention. And we were given an extension for another year, which has just finished. And we're currently in the process of writing up the data. So the main outcome for this study to judge clinical effectiveness was looking at emergency transfers to the paediatric intensive care unit or the high dependency area from inpatient wards following deterioration. And because we know internationally there's varied thresholds for getting into critical care areas dependent on the resource available, we also subcategorise these children to whether they met the metric for critical deterioration events. So that's the metric described by Bonafide as getting into critical care and requiring some sort of organ support in the following 12 hours. And we already know that that metric was associated with a 13 times increased risk of death. So at the beginning of the study, we anticipated that the impact would be measured by some children being identified early and early stabilisation being delivered on the wards, thereby averting the requirement to have to go to critical care for stabilisation. And then on the other end of the deterioration trajectory, we recognise that all deterioration wouldn't be averted, and that there would be some children, because of disease process, etc., who would be non-responders to stabilisation interventions. And for those children, we wanted to see that they would transfer early to a critical care setting in an attempt to reduce morbidity. So I mentioned that we worked with System C. So System C was the company that worked on the studies that I mentioned earlier on in the 2 large university hospitals that led to the development of the National Early Warning Score for adults. And we chose that company because they had a strong track record in research. And we used 2 applications that they have that interact with each other. So Careflow Vitals is the application where the nurses can input the vital signs directly onto an Apple device at the bedside without leaving the patient. The Paediatric Early Warning Score is automatically collected, and we also included proactive screening for signs of sepsis based on modified NICE sepsis criteria. And then the other part of the application, Careflow Connect, is a secure encrypted communication system that works in tandem with Careflow Vitals. And this allows automated alerts to be sent to different people about children who are deteriorating. So that allows us to provide real-time situation awareness about what's going on in patients. The patients that were included in the study were all under 18 years, and we were very careful at measuring our intervention and tracking it, paying attention to each of the chains of the organizational chain of deterioration mentioned before. So the technology had lots of additional features which supported situation awareness about patients. So it required doctors and nurses when they came on shift to log in. There was an e-handover facility, so it was easy if you were on call out of hours that and if you were called to see a patient, you could see on your device some background information about them. There was also a possibility to use the devices for task management, so non-urgent jobs could be sent as text messages. So for the deployment, the study paid for a huge amount of Apple devices for the hospital. And we made sure that there were enough devices on each area for the ward staff to all have a device each, for key people in the clinical teams to have a device, and to have 50% more devices on charge. We also did a lot of work on allowing people to bring their own device and registering those devices on the hospital system so that the software could be applied to those. And we set up processes so that there would be better oversight at ward level, clinical team level, and across the entire hospital about what was happening with patients. And just to give you slight context to this, the hospital at Alder Hey moved to a new building about 5 years ago and went from small size wards of about 15 or so patients to very big wards, 32 bed wards, a huge area for one person to have oversight on. So having some technology to assist in that was useful. And alongside the intervention deployment, there was a huge amount of education. We tracked what was going on and we fed back performance to the ward teams and clinical areas. And we enlisted support from IT to support the technical system, and the study team kept oversight on the clinical system. I mentioned that we set up some automated alerts, and we were very mindful that we didn't want to set up alerts that could actually cause alert fatigue. So we chose just 3 alerts, but all of these alerts needed to be taken seriously. So the first one was having a new suspicion of sepsis, and everybody recognizes that sepsis is a medical emergency. And I'm showing you here on screen what the alert looks like. It tells you a little bit about the patient, where they're located. It tells you what the alert's about, and it breaks down the core information about the information specific to this alert. So it tells you the age of the patient, what we think the source of infection is, and which specific signs associated with sepsis were present. At the bottom of the image, you'll see there's a possibility to text directly back to between the person on the ward and the clinician. So they could say, oh, could you take some bloods, or could you start this treatment, while the person was on their way to respond to the event. Then we had 2 PEWS alerts that were automated. So the first one was having a PEWS 6 to 9, which in our organization means the child is heading towards needing high dependency. And then in the critical PEWS, which were PEWS 10 or more, and in our organisation that means the child is heading towards needing paediatric intensive care. And these alerts were delivered to the nurse in charge of the shift, and they were also delivered to the clinical team, and there was an escalation process tied to these. The alerts arrived on the device and sounded like a text message, and then there was key information on the message about what was occurring. So as I mentioned, we're currently finishing the evaluation, but I can show some early results which might be beneficial for you to see. So I'm showing you in this slide the effect of the absolute number of critical deteriorations that happened and where the patient ended up. So we've got blue bars are during the baseline period where we observed. Interim was halfway through the second year. We implemented the intervention and we allowed it to bed in. And then in the 2 years afterwards, we evaluated what happened as well. So you can see there was a gradual decline in the number of patients that needed to go to the paediatric intensive care unit. Similarly, in the patients needing high dependency, the same. We measured separately the children that went to high dependency and needed to go to ICU within 24 hours because we were interested in understanding was the transfer to HDU appropriate in the first place. And then we also looked at unexpected death on the wards. So overall, just under a 30% absolute reduction in critical deteriorations. And to put that into absolute numbers, that meant that in 1 year, there was 93 children less that needed to go to critical care having deteriorated in the hospital. There was a bigger impact in PICU than there was in high dependency, which makes perfect sense if you manage to get in early, that PICU would see the bigger benefit. Then we also were interested in whether having this sort of intervention in place would improve the timeliness of critical care transfer. So to measure that, we used the Children's Resuscitation Intensity Scale that was described by Parshram in his paper in 2014. And this is a scale of 7 points that measures the amount of interventions that are required to stabilize the child in the 12 hours before transfer and 1 hour afterwards. So early transfer is children transferred to critical care that required less than 60 mils per kilo volume resuscitation and didn't require any organ support. And we saw that there was some reduction in the number of those. In the intermediate phase, this is looking at children that do go to critical care and require some sort of organ support. And that could be non-invasive ventilation or invasive ventilation, essentially single organ failure. And then the late transfers are categorized as the patients that have got multi-organ failure. So they're the ones that are intubated and ventilated and are on inotropes, or have had cardiopulmonary resuscitation. And also we included in here the ones that had an unexpected death or died within 1 hour of getting into critical care. Then we looked at the critical deterioration and the association with the utilization of critical care beds. And we looked at ICU alone, high dependency alone, and obviously the total. And again, we used the same color scheme with blue being the baseline and orange being the post-intervention phase. And again, we saw across the board more than a 30% reduction in critical care bed days. So in conclusion, my opinion is that PEWS, and certainly implemented with some sort of technological support, has improved clinical safety in the hospital. However, the technology doesn't run itself, and it actually requires a moderate amount of ongoing clinical oversight. In terms of technology support, the hospital had to accept that this is a priority clinical system, so that if there were any issues with the technology running, they had to be sorted out pretty quickly, and that resource needed to be in place. we found that the training commitment was large and was reoccurring, particularly in the doctors, because they rotated so frequently. And so pretty much every 6 months, we felt like we were retraining half the hospital. And the whole process of implementing the intervention and evaluating was using continuous quality improvement. And there is an ongoing process, as Karen required, to achieving sustainability and continuing to use that approach to achieve sustainability. So we're currently in the process now of the hospital transitioning to business as usual, and we're trying to embed all of these facets. The hospital's obviously continuing to use the technology. So take-home messages from me are: earlier situation awareness is better for patients and it's better for hospital productivity. Trends are encouraging in terms of process and system improvement, but evidence for patient impact is still evolving. And obviously this study shows some improvement, but it would have to be replicated in multiple other sites to really be taken seriously. We need to pay attention to the PEWS implementation, as Karen's told us, and achieving sustainment, and technology that is configured in a way that makes it easy for users to navigate and use could improve system process and outcome for patients. Thank you.
Thank you so much for this great talk, Jerry, and for the very good take-home messages. We have run a last poll with the participants of this webinar, and I would like to present the results. The answer, or the question was if the participants are using PEWS, and if what system. And wait a second, 53% answered this question. 43% said they use multiple parameter. And then, yeah, 1/4 said a combination system, 1/4 said they don't know, and 4% said single parameter, or 6% said an aggregate scoring. We do have a lot of questions, but due to the time, I would like to ask you this one that got popular. It was asked by Santiago. He said, what do you think about the implementation of PEWS in the pre-hospital setting? Better, is it better to follow the receiving hospital guidelines or to adapt to the EMS system?
So I think it's a very relevant question, and there's certainly a lot of interest in the UK about this as well. Certainly a lot of primary care providers and ambulance services have approached hospitals about this. So currently in England, we're trying to agree a single standard early warning system for use in hospital. And the second phase is looking to include emergency departments and first responders, ambulance services, and then moving into primary care. So we're moving along that route, and I can see why it would make sense to have a single language around deterioration in children that would be understood by everybody. I think the thing that's different in each environment that it's implemented is your threshold for escalation will be different. So in my hospital, where we've got a paediatric intensive care on site, there is an acceptance that you might monitor or watch closely a child on the ward or high dependency to see how they're doing. But if you're in a hospital that doesn't have PICU on site, you might want to transfer that child to another organization quicker. And similarly, if you were in primary care, you might have a distance to travel before you got to a hospital. And again, your escalation point might be earlier. So I think I can see the rationale, but it just needs to be really thought through and evaluated carefully.
Yes, thank you so much. If all the speakers are okay with that, I would now like to wrap up this wonderful webinar with a quick summary. Ursula nicely explained what PEWS means, why it is extremely important, and that it is also a very great area for further research, as the one system is not yet found. Then Karen explained to us why science and research without a proper implementation and monitoring of it is somehow wasted. And she also stressed how complex the innovation PEWS is, and how complex also its implementation is. And then Jerry has led us through the technical potential for PEWS and presented the results of the DETECT study that are very, very nice and encouraging. Yeah, so if I want to ask the speakers if there are any more take-home messages they would like to say.
I just wanted to make everybody aware that we've got a European survey in progress at the moment looking at the use of pediatric early warning systems across Europe. And on the last slide of our presentation, which I think you'll still be able to see when you look back at the details of the Survey Monkey. So I would say to anybody that's worried this is going to take a long time, for somebody that knows your own system, it will take you less than 10 minutes. And we're really keen to understand what's occurring across all of Europe. Especially in understanding the systems that are in place when there isn't a formal early warning, because it will be useful to get a baseline before things change. Thank you.
Excellent. Thank you very much to all our speakers. Probably we can put, the survey in the chat, or maybe, should be nice to have that. And also to the recorded webinar. Thank you very much. We are just in time. Well, the end was a little bit shortened, but it was really interesting. And thank you for our speakers who did a great job. It was really outstanding. Thank you very much. And of course, to Jimena and Francisca, who did a very good job moderating that. So thank you very much. And I hope we will see each other in person, maybe in Antwerp, our next ERC Congress in June, 16 and 17, just a little bit of advertisements. So join us in Antwerp, and bye-bye to everybody. Bye, and thanks.